Thanks, Khanna. I think I just want to spend the last 5 minutes to summarize and close the session, if it's possible, so that we can keep to time. Thanks a lot again for involving me in this session. I really enjoyed all three talks. Maybe this topic is becoming a bit more complex with more options nowadays, and people may be a bit confused about the multiple options. First, I'd like to comment on Dr. Srivana's Kumar's lecture. I really enjoyed this lecture that he gave. My own thoughts based on what he presented. Firstly, the advantages of ticagrelor. I really like the fact that it was a fast onset mechanism with no fear of resistance compared to clopidogrel. The other small points that people may not have picked up is that actually it's quite efficacious compared to clopidogrel in renal patients, especially end-stage renal failure patients. It also has a shorter offset of 3 days before major surgery, so that's kind of nice. The main problem I sense in ticagrelor, besides cost, is the compliance with BD dosing. If you look at the ICER React 5 data, where prasugrel seems to have outperformed ticagrelor, half the patients who had the need to take ticagrelor did not fill their prescription. So a lot of patients actually take it as an OM dose when it's actually effective as a BD dose. That's one issue. The other issue is, of course, the perennial issue of increased bleeding, which we probably have to address. Okay, so observation about the trials presented. Firstly, TREAT study. In the TREAT study, one word of caution is that the median duration of switching is about 11 hours in the study. So my advice is that try to do a switch the day after thrombolysis, or at least 8 hours after. The other comment about the trials was twilight. In twilight, the thing to emphasize was that the switch to monotherapy ticagrelor was after 3 months with patients without bleeding or events. So they actually did tolerated 3 months, and there were a mix of ACS as well as complex stent anatomy. And the counterpoint is that in global leaders, a single agent therapy didn't show much of a difference after 2 years versus a DAT therapy regime. What is unknown about ticagrelor interaction is interaction with NOAC therapy. So currently it's contraindicated for combined use in NOAC. We still don't have much data in the end-stage renal failure patients, although in vivo study seems to suggest that it works better with even lower risk of bleeding compared to clopidogrel. In Dr. Kumar's presented about Sweetheart, in Sweetheart, there was a caution about also when ticagrelor was used, the bleeding risk increased in the registry. So now I move on a little bit to Dr. Sandip's comments. Dr. Sandip also presented a good lecture on in vivo use sharing his data. But I would say that the prevalence rate of resistance is very high in Asia, whether it's India, Singapore, Japan, Taiwan. Up to 70% of patients has signs of clopidogrel resistance, whether it's an in vivo point of care testing or CYP2 C19 heterogeneity, but we don't have such high event rates. So we don't have a good study to say that you should use a point of care testing like Verify Now to change strategy in terms of treatment. So I personally wouldn't advise that, whether it's point of care testing, gene testing, to switch mode of testing, except if clinically relevant, meaning you have an event like a stent thrombosis. One good observation was in Roxana Maran Upentra's twilight sub-study, a monotherapy of ticagrelor was just as effective as a dual therapy of ticagrelor and aspirin as well. It was equally efficacious. So aspirin almost did nothing but increase bleeding in the sub-study. So quickly, in Dr. Makesh, very difficult presentation, but he did very nicely presenting the data. Aspirin, in terms of what is its role now currently, I think is confusing a lot of people. So firstly, I just want to quickly summarize my own observation. Aspirin as a primary prevention therapy, the data is weakening, whether it's diabetic or if you look at the TIMI's DM study and all this other study, it seems to be that you should have quite minimal benefit in primary prevention, even with diabetes, at increased risk of bleeding, especially intracranial bleed. So I wouldn't use much of primary prevention. I think it's difficult. But its role is very strong in secondary prevention. So you establish coronary artery disease, you have multivessel stenting, please consider aspirin definitely as second prevention therapy. It works. So now what's the confusion? Firstly, in our region, do not use aspirin to treat AF. It has been shown, although I may not need to repeat this, don't use aspirin as a therapy for stroke prevention if it doesn't work, except increase intracranial bleeding. The other thing about trying to remove aspirin to reduce bleeding, you have to be very careful, especially in the recent PCI subgroup. You look at the Augustus trial, which tried to take off the aspirin in AI patient using reduced dose NOAC, the stent thrombosis rate was signally higher. So I'm a bit wary. The other confusion comes in secondary therapy for aspirin in combined DPI strategy with low dose rivaroxaban in polyvascular bed disease. So there seems to be good evidence suggesting aspirin, rivaroxaban 2.5 in a COMPASS type patient does have benefit. So I think it's also quite clear that in AI patient using full dose NOAC, you can drop the aspirin safely in stable coronary artery disease patients. So my summary for antiplatelet usage, current thoughts, you have to balance safety, which is predominantly bleeding, against efficacy, which is predominantly event rates, and cost. So we should never ignore cost because cheap doesn't mean no good. So in an appropriately used patient, cheap drugs like aspirin is extremely good. Efficacy, you have to be very careful. When I talk about efficacy, my advice is a strongly risk stratified patient. If they have a high thrombotic risk, you have a left main stenting, bifurcation, multiple stents, you have a recent ACS, prior ischemic event, the polyvascular bed disease. These are high thrombotic ischemic risk patients. And therefore, there is a role for more aggressive antiplatelet regime, whether prolonged that or DPI strategy and extended that post-ACS. So in that mode, against safety. Safety bleeding risk assessment, which was not quite presented because the evidence in Asia is quite weak. We often say Asians bleed easily, but we don't have good data. So maybe a rough guidance is that if you eyeball and assess a patient to be high bleeding risk in Asia, meaning they have low hemoglobin to start with, they have organ failure like end-stage renal failure, low platelet count, liver failure, they are advanced age above 85, and you sense that they have also need for concomitant NOAC or warfarin. These are the high bleeding risk patients, and therefore you need to balance against giving more antiplatelet. Maybe sometimes less is more in this group of patients. So with that, I want to quickly thank three speakers. I really enjoyed their talk. I learned a lot from everyone. And I also like to thank Dr. Khanna's leadership in bringing this very successful Congress. And I really enjoy the very high level science presented in this series of seminar. So again, I think Khanna, I hope you have chance for a toilet break rather than keep continuously spend that. Your toilet must be next door. So I'd like to thank you also for giving me a chance to participate in your scientific session. I think I've overused my time. I apologize. And I hope the rest of the session can continue smoothly. Thank you very much, Khanna.
Thank you so much, Dr. Jack Tan, Dr. Baulian, Dr. Samir Dani, Srinivas, and all of you. We ran a little late in the time, but I will cover up because one of the speakers in the Ironman is down and is not feeling well. So we'll have 5 presenters there. So we'll move on quickly to the next session. And may I invite the panelist of the next session to come. Jack, very nice of you to be here. I know it's almost like 9 o'clock at your place, maybe 9:30. So your dinner time. See you then. See you soon. Stay safe.